And if I continue to show you lots and lots of cases of angioplasty, it won't look nice. So I thought I will show you the way we can prevent complications in the cath lab. This is a common scene. Once you have a perforation, you need to know how to put the pigtail in. So everybody must know how to get a puncture quickly. Look at this case. We had a complex 1-0-0 kind of bifurcation. Can we run it again? We did a stenting in the main vessel. Run it again. And you can see I never withdraw the balloon unless I'm quite sure I've taken a picture. So many times I put a nitroglycerin down. So you take a post-dilatation balloon, deflate, put a contrast down, make sure there is no perforation, and then only withdraw the balloon. So in this particular case, something wrong. We saw some contrast, so we immediately inflated the balloon. We gave protamine. Now this is something which is important. Everybody must know the dose, and the anesthetist immediately is asked to give protamine. So generally half heparin is reversed. Don't reverse the entire heparin. In this particular case, we also had issues about the side branch, which was quite a big branch. So having fixed the, no, don't go to next. Having fixed the main vessel with just balloon, we in fact had to put a stent on the side branch, ending with a bifurcation stenting under this setting. Now this gentleman, same night, he went into atrial fibrillation. He had mitral stenosis. And we did not give him any Clexane for next 24 hours, but atrial fibrillation continued. So we thought everything is settled, patient was stable, no pericardial effusion. So we gave a dose of Clexane, and within 4 hours of this dose of Clexane, patient had huge tamponade, for which we had to sort of put in a pigtail. Patient went on a short period of ventilator, finally, we had to put in a covered stent in this particular area. So taking covered stent was probably not required on day one, but my own feeling is whatever clot had sealed the perforation got dislodged with Clexane. So this is one issue. Even if you are 24 hours and more away from the perforation, no anticoagulation till the patient is discharged. Now, ProGraft is one stent made by Vascular, very easy to track. I agree that there are lots of other stents which you're familiar, but these kind of stents are more for coronary aneurysms, while ProGraft can take you down very easily. Also, MGuard, conventionally not a covered stent, but I mean, we have gone through the MGuard into the side branches, but in situations like this where your stent, covered stent cannot go in, these come very handy, and MGuard certainly is a very, very trackable covered stent. Now for CTO, we used the anchor technique, and the anchor technique, this particular balloon actually gave way, and we had a perforation at this site. So again, a stent graft in this location sacrificed the vessel in which we had used an anchor balloon, and thus patient is salvaged. What about slow flow, no flow that you run into cath lab? Thrombustor 2, good lumen. Most of them have a stillet inside, so you can reach really distality of the coronary circulation, and you can aspirate whatever thrombus is there in this particular site. So this was thrombolized MI on day 2, day 3. And we actually do everything, aspirate, give intracoronary, all the masala that you heard about. But finally, what we used was urokinase after talking to Dr. Prabhakar. And then we bring him back on day 3, a fairly clean-looking vessel, and then easy stent in this particular area. So some of these things like urokinase are not kept in the cath lab, but maybe you should start putting these in the cath lab too. This was a 3-week-old RCA-related infarct, an occlusion at that site. We struggled almost for 1 hour, but we couldn't establish a flow. So this is how you get all the way into distality. Keep injecting whatever you want, adenosine, epinephrine, and so on. And this is how finally we got flow. These are all fragmented thrombus. We got this patient on anticoagulation for 3 months, and we didn't have to do anything to this particular patient. The artery looked very good at the end of anticoagulation. But we do have a clearway balloon, which actually, can you run that please? So this is a clearway balloon kept, go forward, yeah. So here, and again, this is perhaps the safest way. You can inject many things through microcatheter, but remember all these are end hole. And if you inject, especially if you inject fast, not very careful, you can produce dissection into distality and create more problems. Clearway is one very safe way because whatever you inject, the liquid comes out through multi-layered, so it's not looking straight at a right angle to the vessel wall, but it sort of spreads in that area, and thus it's a very, very safe way to do inject distally. What about the vein graft? Can you run it again? You can see that there is hardly any flow, but we persisted because this was a recent total occlusion based on the history. And what we have done here is got the 7 French guide catheter all the way to the distality. Can you run that? Right here over a support with wire balloon, aspirated everything. And this is the kind of picture you get at the end of it. So you need to have something really big to aspirate and suck out the entire thrombus. So here the purpose was served by the 7 French. Luckily, it was a vein graft which was looking straight down, and you could take your 7 French guide catheter down. Snares, something very important. This is a PDA device. Run this side, please. And you can see when you release it, the device actually slips into the aorta. So this was actually picked up by the snare. You can see that the snare with this, no, the previous one, we got it into the IVC. At this stage, the snare also cracked as we were trying to withdraw, so we had to put in one more snare. But you're already in the safe territory in the IVC, so no issues. What about the left wires? You can see a wire which was left in the IVC going down to the SVC. So we initially use a pigtail catheter, make loop, try to catch it. Didn't work, so we go pick up a snare, and you can make out that you're able to bring it out very easily with a snare. What about stop strut wire? This was, the stent was deployed, the wire was left on the side, and the wire could not come out despite pulling in many ways. So this was again snared out and wire came out. So this was a stent which was actually, we were trying to push it, but it could not go into the circumflex. The issue here is a very long, almost 6 or 8 millimeter long left main, and then an acute angle bend. So we're not able to push the circumflex stent into the vessel. The stent got stuck here. There was an already deployed earlier old stent at this particular area. So we had to get it out. So we used a mother and child technique to reach through this catheter into the distality of the left main, not possible. So ultimately, we used a snare, and the wire, the stent came all completely open in the proximal portion. But it did happen that through this too, we were able to get this snare out. This is not very common, but radial catheter loop not opening. We're not able to get the catheter out. And again, we had to put a snare from the groin, straightened up the loop by putting a stretch on the groin as well as the radial hand. and then we are able to move this catheter out completely. So these are all thoughts which come to your mind. It needs a huge experience, but you can't be experienced in second year or 5 years of into practice. So you need to sort of have your presence of mind to do what you should be wanting to do. So this is a case. Can you run it again? We have extreme calcium at this particular site, and at this stage, even the balloon was not easily tracking into the diagonal. This was the culprit artery. And this is the kind of a case where a guideliner comes very useful. You've already seen lots of cases, but see, don't try to push the guideliner over a wire. The guideliner must go along with the balloon. So keep the balloon a little bit ahead of the tip of the guideliner. Can you run this again? And you can see the guideliner lying here and the stent tracking down very easily through the guideliner. So whatever you take, the guideliner must have a balloon or a stent ahead of it before you go there. And sometimes in these kind of situations, the lesion looks pretty simple, but we are not able to get anything down. So this is a guideliner, and through the guideliner, can you run this? We're not able to get the cutting balloon down. So finally, we got a balloon to the distality, got the guideliner, the guide catheter, a 620 guide catheter to the mid portion of the RCA over a balloon support. Now, here again, we had to change the guide catheter. There are certain brands of catheter which are not so flexible, but certain catheters which are extremely flexible. Can you run this again? Once we got the, can you go back? The stent tracked through this position of the guide catheter very easily. So guide catheter, you could take it down, and thus you can achieve a lot of safety. Next. In this particular case, you have a wire down, but a sprinter is not going. And here we bring in a Corsair. So you see Corsair going very easily through this. Now, when you're pushing your Corsair, you're not supposed to just push it like you push a balloon, but have some kind of rotation, some kind of tension. And whatever you twist from outside, the Corsair is good enough to take it to the distality, and thus you would see that the Corsair crossed, and over that, yeah, run this please. Keep running, don't show the blank screen. Next. And then the balloon cross. So whenever you're talking of very resistant plaques, you talk of cutting balloon or rota. And here in this particular case, you have a bifurcation, some kind of aneurysm in that area with heavy calcification. So here what we have done is we did a I mean, these are the standard cutting techniques that we use. A FlexStorm has a length. I mean, previously the balloon used to be just one blade, but FlexStorm has multiple small blades so that it can take the bend. It can bend over acute bend too, while angiosculpt is just a wire which is going around the balloon. Again, quite useful. The angiosculpt will probably reach many lesions where a FlexStorm cannot reach. So reach is also very important. So in this particular case, we did rota on the calcified LAD, and we used a FlexStorm on the origin of the diagonal. And this is the final result of a bifurcation in this kind of setting. So you need to rethink. In this kind of case, if we had just gone with, say, a non-compliant balloon, almost always we'll end up with some kind of dissection, perforation, and so on. So you need to plan your case very effectively. And to sort of take you towards the end of my talk, so many times you come across these kind of zigzag bends. This gentleman was actually suggested bypass surgery just for these bends. But you and I can know that you can straighten up everything with a long catheter. Now, long catheter or long sheets, say 50 millimeters or longer than that, huge support. So whenever you think you are dealing with a complex situation, take this long catheter. It increases your pushability extensively. And even if the aorta is slightly opened up, you can use these kind of long sheets. This is what you do for air embolism, not very common, luckily, with us these days. But as you heard, never lose heart. You can get onto somebody's chest. I know of a diagnostic angiogram, first shot, a lot of air went in. Cardiac massage for almost 1 hour. Patient went home walking on day 10 with absolutely normal ventricle. And of course, never fight with your surgical colleagues. You can fight for indications of a case, but never for the therapy. Take their help whenever you want. Thank you indeed.